Hey, and welcome back to the Business of Healthcare podcast and our series, How It Got Commissioned. In today's episode, I'm speaking with Rukshana Kapasi, who is the Director of Health at Barnardo's, the UK's largest children's charity. Rukshana talks us through an initial 3-month pilot they got commissioned to help reduce frequent attendance at A&E. One of the key takeaways I took from this interview was the importance of looking at your partners in a slightly different way and thinking and maybe going a little bit further afield. And Rukshana highlighted in their experience, they are able to tap into other sources of funding, which those of us in primary care, secondary care may have no idea exists. So I think that there is definitely an opportunity to not just look for funding from your initial commissioner, but to look for funding opportunities elsewhere. I asked Rukshana for one tip. She gave so many. She gave about 5. So definitely make notes. Definitely come back to this episode. I think, there's so many gems in there. I know you're going to love it. Hey, Rukshana, thank you so much for joining me on the Business of Healthcare podcast and on this series called How It Got Commissioned. How are you doing?
Doing really well. And how are you doing? It's great to be here.
I'm good. Thank you for coming back. Would you be able to share with our audience a little bit about who you are and what you do?
Yeah, absolutely. I'm Rukshana Kapasi, the Director of Health at Barnardo's, and I was brought into Barnardo's, which, for people who might not know, is the largest children's charity that was set up about over 150 years ago. And my role in Barnardo's is to really develop the organisation as an integrated health and social care organisation.
And how long have you been in post now?
It's been nearly 5 years. Yeah, so time flies.
Okay. So the purpose of this series is to help and provide examples of how organisations have had services commissioned outside the usual tendering route. So would you be able to share what was the service or the innovation? Give us an overview of what you're going to be discussing today.
Yeah, so I'm going to be talking about the family support workers in A&E as an initiative that we put in place to really reduce those repeated avoidable presentations of children at accident and emergency departments, to provide kind of in the moment enhanced non-clinical support to children and families, to really try and use it as an opportunity to drive down some of that non-urgent attendance.
Who presented the problem to you?
It was a local problem that was actually identified by a community health trust in Hertfordshire, where we ran a number of family hubs at the time. And they were working together with the Lister Hospital. And what they were finding was that there were a lot of children and young people coming to A&E that they felt could be more effectively managed in primary care or community settings. And when they actually looked at their data over a 12-month period, they found that, for example, 39 people had come to A&E for 378 attendances, with 8 or more coming for the same reason. And the most frequent person actually had come 18 times in 12 months for the same reason. A lot of those children were under 5, and the top reasons why they were coming into A&E were for social needs, were for respiratory health issues, mental health issues, that was putting a huge strain on staff because they just felt that they couldn't actually do anything to support these children and families, and they kept seeing them coming through the door again and again.
Okay. So how did you get the service commissioned?
So what happened was that in looking at the problem, Eastern North Herts Acute Trust and Hertfordshire called us into a meeting and presented the problem to us. And they knew that we actually had family support workers in our family hubs that were doing a whole range of sort of support for families that was really the type of support that people that they were seeing in A&E needed to have. Things like health promotion, signposting, and meeting some
Yeah.
of those underlying causes of poor health. And so they talked about the model. They talked to us about basically, could we put something in place to test this idea? And at that time, we were very lucky in that there was some short-term winter pressures funding that became available. It was only 3-month funding. And as with all of these things, you had kind of 2 days to reply, put a model together, and get
Okay.
something in place. And we were very lucky that this was a tried and tested model that we'd been using for 20 years, but in a different setting. And so we were able to put something together around that model, how we would actually work, and essentially not go through a procurement process at all, just presented the idea on paper. And on the basis of that, the ICB actually kind of said, yes, this actually meets some of our needs around reducing those emergency attendances and trying to do more in primary care and the community. So that's how we got it commissioned, and it was a standard memorandum of understanding agreement that we
Okay.
created between the three organisations. We did agree, what we were going to deliver, the hours that we were going to deliver, and looked at sort of job descriptions and all of that as part of that, and how we were going to mobilise. But we created, that whole structure by having that discussion between ourselves.
Were you initially put off by just 3 months? It's a lot of effort for something to stop just as you're getting it started.
Yeah, absolutely. I think it was a risk that we wanted to take because this is, we know this is a long-standing issue nationally as well as locally in Hertfordshire. So, for example, we knew that, over the last 10 years, there's been a 30% increase in children presenting to A&E. There's been a 40% increase of babies coming. It is something that other systems also need to solve. And we thought that if we can, from the beginning, try and collect data, be really evidence-based in our approach, that we could do something. But actually, it was a really short time. And what actually happened was that we ran it in the end for 6 months, because it's a very cost-effective model. We used our existing kind of management structure to support the family support workers, and I managed to find another 3 months worth of funding so that we could really give it a proper go.
Yeah.
And that was using our kind of corporate funders to,
Yeah.
add to that.
And was that last year?
About over 18 months ago now. So,
Okay.
yeah.
And has the service been repeated, or was it just 6 months and it came to an end?
So the service came to an end after 6 months. But what was really brilliant was that we were then able to present the data and the evidence from the service to NHS England to say this is showing some really promising results, because 87% of families are actually saying that they wouldn't come to A&E again for the same problem. Over 90% are feeling more confident around actually,
Yeah.
sort of supporting that particular health condition. And they, as a result, then thought this would be an excellent model to trial out across all 7 NHS regions. So
Okay.
they then put, a large amount of money to test this out in 7 regions as a model.
Brilliant. So you mentioned the three organisations initially. What roles were involved in the kind of coming together of this service?
Yeah, so it was the Children's Services Manager in
Yeah.
Hertfordshire Community Trust. It was the manager who was in charge of A&E in the Acute Trust. And then on our side in Barnardo's, it was the Children's Services Manager as well as a public health consultant that was
Okay.
involved in developing the model. So we were really trying to look at all angles.
Okay. What mistakes or kind of learning points were made along the way?
So, one of the learning points for us was that because we had to mobilise the actual service and use the money very, very quickly, there wasn't time to actually socialise and communicate this model to everybody that needed to be
Yeah.
communicated to in the hospital.
Okay.
So we know that there's a lot of rotating staff, and also there's a lot of teams that feed into A&E, like health visiting teams, like GPs from primary care networks, like the multi-agency safeguarding hubs, and we didn't have time to do that. So in some cases, our family support workers kind of arrived with some staff not knowing who they were and why they were there.
Okay.
And the other kind of learning point for us links back to that time pressure around how quickly we had to mobilise it, where we didn't have time to discuss properly with the teams, how does this fit into the triage model that's used in A&E? How does this actually fit into some of the handover team meetings so that the family support workers can really be integrated into all of that? So we were lucky that we put our most experienced family support workers into the service who could hit the ground running.
Yeah.
And they were able to really navigate all of that on the spot, and ended up actually taking the service to different levels that we didn't expect, like running
Okay.
sessions in the intensive care unit for parents to prepare them for going home as well.
Okay. Brilliant. What would be your number one tip that you would give to somebody looking to create a service that doesn't necessarily, like exist on the commissioning pathway at the moment?
Um, so I think I would probably give a few tips, Tara.
Okay.
The first one is actually to really nurture that relationship with commissioners or transformation leads, to make sure that whatever you're thinking about is a strategic fit. So really demonstrating how it hits the national, local priorities and key performance, data, and have a really clear understanding of the risks and pressures that the commissioner is facing
Okay.
within that, and knowing what gaps there are in the system and how your service will actually benefit not only service users and patients at the end of the day, but also help to fix some of those system issues. And I think that particularly at the moment in the NHS, where there is a lot of change, and primary care networks, GPs, and a whole range of system partners are having to sort of come together to learn how to work together.
Yeah.
I think that this is a really, really important area. Um, and I'd also say that within that, don't be afraid to just really talk to commissioners about the models and pilots that you're working on, even if the results aren't in. And getting that sponsorship from a senior leader so that they can really endorse it to other commissioners is really, really important. And invite commissioners, to your service, and really schedule in those follow-up calls. That's something for us that really, really worked.
Okay.
Um, and then I think that the other thing in terms of tips is to really back the service with evidence, and back yourself as well. So be very data driven in terms of not just capturing, the quantitative data,
Yeah.
but also some of those case studies around the difference that it has made to patients and some of the system savings as well. So one of the things that we were able to demonstrate was that this particular model provided a £3.05 return for every £1
Okay.
that we invested. And that was actually quite powerful. And having, actually asking the right questions around, would you come back to A&E again if you had the same issue? Was a really powerful question for us to ask, and really thinking about those types of questions from different perspectives is really, really
Mm.
important. Um, it can sometimes be a bit overwhelming when you're dealing with a complex issue to think I've got to boil the ocean and actually fix all of these system issues at the same time. So don't be afraid to start small, and do it kind of one step at a time. And I think that, the final tip that I'd say is that having the right culture within your team and organization to really test and learn and develop your particular USB is really important. And thinking outside of the box in terms of really innovative ways to find funding is also really important. I think that, sharing that learning around people just testing things out, trying things out, is a continuous process that you can
Yeah.
build into team meetings and things. And there are lots and lots of sources of funding at the moment. I know that the government is trying to encourage us to look at kind of social investment on return, so working with the private business sector.
Yeah.
We know that there's the 24, not 24, 42 neighbourhood pilots that are going to be
Yeah.
rolled out, but also the innovation networks that are there as well, that have got access to lots of information around sources of
Okay.
funding. Um, and I guess the other thing, which was, our USP, was that we really tried to develop this service with stakeholders. So not just all the people, in the multidisciplinary team, but actually involving service users, patients, etc. in
Okay.
that. And that actually threw up some interesting insights for us, but also it meant that we knew what patients wanted that service to deliver for them as well at the end in terms of outcomes.
I just ask, at what point did you bring the service users into the conversation?
So what we tried to do is obviously at the beginning we agreed that we needed to get the funding. So it was after we got the funding
Yeah.
when we actually started working the service on the ground. But ideally, if you had more time, I think it would have to be at the beginning, at the design conception stage.
Okay. And you mentioned kind of the new developing neighbourhood models. Where do you see a role for Barnardo's in some of these models?
Um, One of the things in terms of the new neighbourhood models that I think might be missing a little bit is that uh, there could be a tendency to focus it on clinical need only and meeting clinical need and comorbidities of groups of patients that perhaps draw the most on NHS resources and things like that. But I think there's a real opportunity here in the community neighbourhood models to really think about that prevention approach, that early intervention, and the local resources of local organisations and local VCSE sector organisations can draw on in supporting that, because we know a lot of health issues, are affected by poor housing, by,
Yeah.
not being in employment, by air pollution, a whole range of things. And very often it is by working with local people and really actually encouraging that sort of behaviour change and that supported self-management that you will get to some of the real changes around health behaviour,
Mm.
and things that will really keep people well for longer.
It's also interesting, you mentioned that there are kind of lots of pots of funding available. I've not heard anybody say that there is money available. And I think sometimes the expectation is, what can we do without additional funding? Because there will never be enough. So you've got this 3-month pilot. Is it helpful to keep funding these really short pilots? Or can we do things differently together with the resources that we've already got? And if that was the case, would you have been able to deliver that service if there was no additional funding?
I think it's really, really important for us to begin to think differently about how we can make changes without necessarily drawing on more resources, actually looking at our resources and how we can actually make that work differently. I would say that in terms of this particular model, if we had had a conversation with our commissioners who we deliver the sort of family hubs and family centres to, and say, could we use 2 of our family support workers over a 3-month period to try out a different way of working with
Yeah.
the acute trust? Would that be okay? And we feel confident that we could meet other needs in this way. That it would have been possible, because actually with this particular service, we didn't cost in any management time. We didn't cost in any of the time of the acute trust to sort of oversee this, or the community trust either. It was a really kind of low cost effective model that just paid for the time of the family support workers.
Okay.
So I feel that that there is, and I think that one of the things that perhaps working in partnership with other organisations brings is access to sources of funding that you wouldn't
Yeah.
normally think of.
True. Yeah.
So we have relationships with corporate partners that have been long established over decades, who
Yeah.
actually really want to make a difference to the lives of children and young people. And we're able to have those conversations with them. And they are the partners that support our poverty fund, that allows us to
Yeah.
provide grants to families, that might need a washing machine or whatever. Um, and they are partners that, fund our employment training and skills programs in a whole range of areas. So I think that, by working in partnership, to see how you can leverage different sources of
Yeah.
funding is really, really important. And actually, Tara, one of the pieces of work that we're doing at the moment with one ICB, is that they have looked at corporate social responsibility in the contracts that they procure, and they have actually upped that from 10% to 20%.
Okay.
Um, and local businesses have accepted that, local suppliers have accepted that,
Okay.
because actually these are really large contracts worth billions that the ICB has had. And what they are using this money for is to fund prevention and early
Yeah.
intervention programs of work. So I think there's a lot of creative ways when we think about actually how do we commission procure services at the moment? How could we leverage more? And why don't we just ask the question? Because local businesses really do want to support local communities. And there are a lot of people that are interested in making that difference towards health and well-being.
Yeah, I love that. And I hope that gives people lots of ideas. I think the other thing that you've not mentioned, and the reason why I wanted you to come on, is to remind people that there are lots of stakeholders out there, like Barnardo's. You don't work with that many PCNs. There'll be
Yeah.
lots of people that will think, oh, like, can we work with Barnardo's? Like, what do they do? Like, what services they provide? So I think it's very natural and normal to want to work with your local partners, but there are lots of organisations, private, public, third sector, out there that the patients' paths cross. So I think that hopefully there's loads and loads and loads and loads of tips that you've shared, and really appreciate that. But I would, encourage people to look at other organisations. The caveat is, if you're working with a small organisation, they just might not have the funding, but it's worth kind of at least having a conversation.
I think it absolutely is. And, I'm very aware that, we're a large organisation. We
Yeah.
provide 760 services and 187 health commission services. But in a lot of those services, what we actually do is we work with local grassroots organisations. So those services are very locally based. They recruit from the local population. And we enable and support those smaller organisations to build up the infrastructure, because a lot of organisations may not be able to meet the rigid, clinical governance, quality standards, etc. And we have that infrastructure internally within our organisations, whether it's safeguarding, whatever it is, to really support smaller organisations with policies, procedures, good practice, so that you can feel really assured that you will get high quality, sort of safe, effective services, but also you get that spark of innovation, that spark of different ways and approaches of doing things, looking at problems and finding solutions as well.
Okay. Thank you so much. I will leave your contact details in the show notes. And I really appreciate your time.
Thank you, Tara. Always a pleasure.